All right, hello everybody. Welcome to our last PPW Echo session of 2022. We've got a full session. We're going to have a didactic presentation from Amanda Newhouse, a case discussion from Jen Price, although I don't see her on yet, but she'll probably be joining us here a little bit later. Then also we're going to have a Zoom poll about thinking about topics for 2023. We're going to have a second round here of sessions. They're going to start in February, though. We're going to take January off to kind of do prep with the curriculum and things like that. So we really want your input. So we're going to do the didactic, then the poll, and then the case. So we'll try to break it up a little bit. But this is really an opportunity for everybody to voice their opinion about what topics, if you have a speaker in mind, anything like that. Don't be shy. We want to record all that information and then help us build the curriculum for 2023, which we will then share in January as we get ready for the next session in February. So with that being said, are there any questions, anything before we get started? Okay, in the meantime, if you haven't already done so, put your information in the chat. We're using that for attendance and for CME. We're looking for your name, your email, your organization, and your credentials. All right, Amanda, I'll pull up your slides and we can get started.
I can pull them up if you don't mind.
Oh, okay. Hold on one second then.
I have to control them, Jay. I have issues.
Hey, that's a different echo. Okay, go ahead. You should be good.
Hi, everyone. I'm Amanda Newhouse. I'm clinical social work faculty from WVU Medicine. I'm just going to pull up my slideshow. Everybody can see this? Perfect. Yes, so if you all can help me man the chat, because I can't do both. But so I specialize in infant mental health. So I'm going to shift our didactics a little bit today from focusing on the pregnant person to the parenting person that we might be working with. So hitting some of those topics, I'm going to talk a lot about building a reflective capacity, because in infant mental health, we talk about a reflective capacity and how we can create that and how we can build that. And I'm sure that many of you are already doing this. So maybe it just organizes some of this for you and helps you understand how very important that is. So when we look at, my bar's in the way. Okay. So when we look at reflective and that in that definition, I love these definitions, right? Because when we're building a reflective capacity, we really look at deepening that thought and going deeper and reflecting on oneself. But when you reflect on yourself, I love the definition of reflecting light or other radiation, a colorful reflective glow, because I think that, pregnant people and parenting people really, we wear ourselves thin at times. And so reflecting deeper and how we can remain emotionally available helps us to really find a new glow about yourself and helps build this kind of reflective radiation that I think is just wonderful. So I feel like a lot of the times when we say like pregnant women are glowing, sometimes they really are, because they're really reflecting their own capacity. And the minute a pregnant person becomes pregnant, they start kind of reflecting on what type of parent they're going to be, what type of parenting they've had, and this can create like a natural glow. I might be able to move forward. So we know that when we're dealing with pregnant people who are in recovery, that they are highly motivated. And so we deal with a lot of women or pregnant people who come in, they're ready to work. They're more driven to remain abstinent or find out how to best help them and their babies. So a higher level of willingness. They do tend to be younger. So a lot of the times there's a shorter progression in their disease and they have more supports. Sometimes they can be really overwhelmed being younger too, because they're not fully grasping some of that. Family supports are huge. So we know that a lot of the times being younger and less progressed in the disease, they've not broken a whole lot of ties. So sometimes they do have more supports. In what we're doing when we're building a reflective capacity is for the pregnant and postpartum population, we're really looking at working with that dyad on building some optimal bonding. And we know that that's important to build resiliency. We know that a parenting person and the baby need to have that bonding and attachment. We know that they need stability. They need to focus on their health and well-being, but not only for the baby, for the parent as well. So when we think of reflective capacity, we think of, sorry, hold on, let me go back. No, you might have been better off, Jay. So when we think of reflective capacity, we think of, moving from reflecting on oneself to now reflecting on the baby and those interactions. And we look at those interactions and how we can deepen them and what they're triggering for individuals. So the reflective capacity really allows pregnant people to reflect on their own emotions that they're bringing to it. And then once they're parenting, really what this other life in your life is triggering for you, and what emotions are they bringing about, and reflecting on that, where they're coming from, and exploring some healing with that while you're trying to understand your own child, their capacity for development, and what their needs are. Sometimes that's really hard when you have a cranky baby that's screaming and you're not getting enough sleep. So it's really hard to stop and do this. And that's why, as providers, we want to be able to understand this and know how to open this up for individuals. We know that there are protective factors for this dyad. We want to promote that resiliency and attachment. So we want to make sure that attachment is occurring. Babies need to co-regulate before they can regulate individually. And if you don't have somebody that's in a reflective capacity, that's reflecting on their own emotions and what they're being triggered or what they're bringing to that interaction, then sometimes they can be blocking that co-regulation and not even realizing it. And so we want to make sure that that's flowing. We want it to be going back and forth and make sure that they're openly expressing it and exploring that. And sometimes it can be hard, especially for the population we work with, because there's sometimes been a lot of damage, and we'll talk about that. But the protective factors are those interpersonal relationships, right? And so that sensitivity, safety, consistency, we want to provide a parallel process for that. So we want to make sure that we are providing a safe place and that we are consistent in these individuals' lives and sensitive as well, so that we're modeling that for these pregnant and parenting people to also provide that sensitivity, that safety, and that consistency for their child. And so we want to make sure that we're doing that parallel process, because many of the women that we work with have a history of trauma, and we know that trauma reverberates back and forth. So we want to make sure that we're providing some of that stability so that we're kind of lessening that reverberation and building some resiliency. So with being sensitive, we want to make sure that, did somebody have a question? Thought I heard someone. No? Okay. We want to make sure that we're welcoming, that we're inclusive, that we include everybody, right? And that we kind of put our biases at the door. We want to make sure that we're non-biased, we're opening and engaging. And I'm sure all of you can attest to this. The population we work with, when you work with pregnant and parenting people in recovery, that they can sniff out a fake person as fast as, like, I don't even know what metaphor I want to use, but they can sniff them out pretty fast, and they'll call you out on it too. So making sure that we're genuine, we're genuinely engaging and caring about this population. And I know I'm preaching to the choir, because almost everybody that works with this population is very sensitive and engaging to that, and understand the stigma that can be out there and how difficult that can be to engage when there is stigma. And so they need trust, and we have to make sure that we're building that trust. How we build that trust sometimes is being that consistent person, helping them with their treatment, making sure that we're helping them with resources as well, and education. Once you build that trust, you're opening floodgates. You can help with education, and people will listen and understand it and utilize it. And same thing with treatment, they'll try it or tell you they're not trying it, right? So that trust is really that foundation. You want to be that safe spot. You want to be that trusting person. Again, just understanding that the population we're dealing with, when you're dealing with women or pregnant people or parenting people with a substance use disorder, 80% of them have some complex trauma, and this can be at multiple levels. And trauma is definitely linked to emotional attunement, which impacts attachment and then impacts resiliency, right? So it's like a domino effect. Many of the women that we work with deal with caregiver betrayal. So kind of what we mean by that is, I work a lot with kinship care, adopted parents. And so a lot of the times, especially in kinship care, some of the pregnant people and parenting people that I've worked with have identified as they struggle with a substance use disorder and their kids might go to kinship care, that, they have family or relatives that are choosing the kids over them, or trying to take their kids, or, caring for their kids more than they've cared for them, right? And that's a legitimate feeling. And so we have to be open to understanding that and the trauma that it can produce, and then the pattern of interaction that it can create between each of those dyads, right? And so that's really opening that reflective capacity and talking about that, reflecting on those emotions and understanding that. We have a lot of pregnant and parenting people that come from families where there's been maltreatment, exposure to violence. Exposure to violence completely rewires the brain, even in utero. So can impact babies in utero. And can create that barrier and reduce that reflective capacity as they have their baby to remain emotionally available, especially if we have pregnant or postpartum people who have experienced that violence in rape, or the children kind of look like that perpetrator, right? It can be really difficult to open up that reflective capacity to be open and willing to manage some of those emotions. That's a struggle. And then loss. I mean, we know that, of course, losing a person to death is one thing, but we have pregnant and parenting people who have experienced loss in so many ways, right? Loss of relationships, loss of their independence, loss of their children, maybe through being placed with other individuals, loss of that interaction, loss of time. And so they deal with loss on many different levels. And so understanding that so that we can open that up. And one thing with reflective capacity is we talk about parental sensitivity. So this is one piece that we really work on when we're reflecting, is noticing signals. So baby signals, noticing them, interrupting them and responding to them, when to do that, right? That's that sensitivity that we want to provide them so that these babies feel safe and secure, that links to that attachment. Noticing signals are important. That's how babies feel like they're communicating effectively, that they're being taken care of, right? That builds attachment. And sometimes when we have parents who are dealing kind of with their own emotions, they have a very difficult time opening this up and noticing signals, right? And they're kind of in their own heads. We deal with a lot of parents that have postpartum depression, and postpartum depression is like a number one indicator of toxic stress for babies, because for those of you who've worked with postpartum depression, there's like a blank stare, right? They're present, but not present. They're not mentally present. And so they have a hard time noticing signals. And so sometimes we have to do that. Sometimes they come from a parenting background where they don't know what they need to do as a parent. And so they don't know what signals to notice, or how to interrupt those signals, or how to respond and react because of the history that they've had. And that's really hard to admit. I don't know of any parent who can confidently say like, I can't really read my baby's cues, right? I'm lying. I've had one parent that has come in and said, I need help reading my baby's cues, right? Willing and open. But that's a really hard thing to admit. And so just being aware of that so that we can provide that reflective capacity and help them with that. And we'll talk about different strategies later on that can help with that. We work on sensitive parenting to build attachment, right? So making sure that the parenting person is having an adequate perception. So many of the times we work with a population, and when you're dealing with a population that has been exposed to substance use disorder and trauma, sometimes they can have some perceptions that are off, right? Sometimes that shame and guilt can kind of create a barrier for them to have an accurate perception or interpretation of what is going on. It kind of triggers some of those old emotions, which is exactly what we want to try to work through. But that creates a barrier between them and the child and that dyad. And so that's where you have to do some dyadic work to help reframe some of those thoughts, those perceptions, and how they're interpreting things. And not only with the child, but relationships around them that would affect the child, right? And so you're doing a lot of this reframing that helps build the attachment for them and the child. And so while you're working on some of that reframing, you're really healing some of that because you're exploring that. And this allows them to give more of a prompt response, right? And more of an adequate response. Like I had a mom one time, that she was co-parenting with her mother, and so it was the baby's grandmother and biological mother, and the mother was doing well in recovery, but she's like, my baby hates me. And I was like, well, what makes you think your baby hates you? And she's like, she definitely prefers my mother. She says, when I'm in the room, she's always screaming and crying. And so we kind of explored that, what her emotions are around that, and how difficult it was really for her to accept that her baby's preferred caregiver was her mother. And so we did a lot of work around that. But the baby was really, so this mom in particular had a really difficult time with physical touch. And that was one of hers. She had to work hard on that. So she had a hard time, her caregiving for the baby was very distant. And so she had a very difficult time touching. And we know that touching is sensory nourishment for babies. So of course the baby preferred the grandmother, but the baby so very much wanted that mom's interaction, because one thing that had attached that baby to mom was her voice. The baby was very familiar with mom's voice, because as we know, the babies can hear voices in utero, especially in the third trimester. But throughout this baby's life, mom has been involved verbally and in a positive way. And so this baby wanted so badly mom to pick her up. So once we worked through some of that and mom was able to pick up the baby, she saw a much better response. But we had to really work through some of those reframing those perceptions and interpretations that her baby hated her, to give her a more adequate response and prompt responses, right? When the baby would cry, picking her up and having that physical interaction. It took a lot of work, but she was able to do it, and she was able to build that attachment that was already there because the baby really wanted her involved. So it was really nice. And she had the support of her mom. So even though the baby preferred the grandmother as a caregiver, mom had her mom's support. So that was really nice. Like I said, that support is huge when you have some of that family support. But that's an example of her perception, right? And how easily, she had so much work to go through, and how easily that could have created such a disorganized attachment between that mom and that baby. But she was still trying, and the baby she was just misinterpreting some of that. She had a lot to work through. We know there are tons of risk factors, right? And so when you're working with families in recovery, of course, there are some impaired attachment on individuals. Like I've worked with a couple moms who are that positive interaction is really difficult for them because they've never really had positive interaction. And so sometimes it's just stepping back, exploring that in a reflective capacity so they can reflect on their own. Once they gain that insight and they're ready to work towards it, it can be difficult. I think back to one of my moms who was like, I just can't say positive things to my baby. And so, we would practice saying those positive things. And that seems so simple to some people, but some people it's not. When you've had an impaired attachment, and even, she's had some maltreatment along with that. And so, and if you look at the risk factors, many of our families that we work with have more than one of these risk factors. Usually when they have a couple, they have a lot more than that. And so working through some of that can be really hard, but it's super embarrassing. Nobody wants to admit that they can't say positive things to their baby, or they can't find the positive things. And I think especially for a lot of our parents in recovery, when I hear parents in recovery talking about becoming a parent, it's such a positive view most of the time, that they can't wait to be a parent and they can't wait for somebody to love them, or that they love this person. And then they have all of these difficult times when they do have an impaired attachment or maltreatment. So helping them kind of work through that, because it's kind of like when you have these high hopes and expectations, and then it doesn't always follow that way. And parenting is tough in general. And so then adding some of your own struggles in with that is really difficult. And other stressors. I mean, we know families in recovery that have so many stressors. I mean, we've talked about it here. I can't even imagine doing everything that these families are doing. Like they should receive like awards for everything they're doing. I can't even imagine going through everything they have to. But like the economic hardships, I mean, finding the resources to get their license back or find a home and get a job and do all of this while they're trying to, sort through legal problems where they have to do UDSs for us and for everyone else under the sun. Like it's so much, right? And then the emotional distress that comes along with that, and possibly the trauma that they're dealing with underneath that. I mean, that's a lot. And then imagine, some of the other risk factors of like prematurity, like having a baby that's premature and worrying about that, and the shame and guilt that can come along with feeling that you've caused some of this for your child. And that's so much within itself, and not having supports to help you along with this. Like I said, the most successful families that I have seen have had supports. The ones that struggle the most really don't have supports. And that's hard, because I couldn't imagine going through this by myself. I mean, it really does take a village to raise a child. And like that's and I feel like the recovery community really does create a village. Like people who are really in recovery and working their recovery, it's amazing how they pull together for one another. Like it makes my heart melt every time I see it. And I'm fortunate enough to see it almost on a weekly basis. So I am very happy that I get to see that. But for those who don't have those supports, it's so hard. I can't even imagine. So making sure that we're providing compassionate care is important. Making sure that those resources are available, helping identify newborn care, right? Talking about breastfeeding and bonding. It is always the pregnant person's choice of what they want to do. But if they choose to bottle feed, still finding some of those opportunities to bond. I think I've talked about it in here before. Probably you guys have probably all heard all of my stories, but with the bonding, I think it's just so amazing. I do a newborn behavior observation, and I had a mom who was not breastfeeding, she was bottle feeding, but she would take her robe down in the hospital and place the baby on her chest when she would bottle feed. And that's perfect. I was like, you're doing such an amazing job, right? So I try to find mastery wherever it is with moms. Mood changes and poor sleep, right? Those go hand in hand. So just making sure we're educating on that and providing compassionate care around that. Mood changes are completely typical after you've had a baby and your hormones are regulating, totally normal. But then if you add poor sleep on top of that, it's definitely normal. I get super irritable if I don't get 8 hours of sleep. So I can only imagine what getting 4 hours of sleep can do to somebody. But we're working in the reflective capacity. Like I said, we're really shifting from just the mom to mom and baby into that dyad, but understanding and having compassion around everything they're going through. Like I said, there's so much that they're dealing with. And then on top of it, some of the other pieces, right? Like financial stressors, like many moms lose their insurance because they're no longer pregnant. That's a huge stressor, especially if you have ongoing problems or you're in recovery, right? How are you going to pay for this? So that can be really difficult. And then, cultural mom norms. That's a huge stressor. And we talk about that. We just talked about the stress of the holidays. And, a lot of the parents in our group talk about, when people post all these Christmas pictures of huge Christmases with their kids with a million gifts, and they know that they can't provide that for their kids. And then we talk about ways to manage that stress. And I mean, is that realistic? And what does that do for kids if they have all of that? Like they don't really need that. So let's talk about what they do need, and really just that reflective capacity on how, a better present is their presence. And so we talk about that and the importance of that. We also explore sensitive disciplining in reflective care. So we talk about positive reinforcement from the very beginning, right? We talk about how important that is, even with babies, right? You see it like even at 6 months, you see babies kind of start testing those limits, and positive reinforcement is great even that young. Sensitive timeouts with toddlers, right? So we talk about that even as early as 12 months and sometimes a little bit sooner. Not necessarily having timeouts, but being emotionally available and teaching their kids how to properly behave and what behaviors are more important through some positive reinforcement, and then how to give a little bit, not necessarily a timeout, but just kind of removing some of your attention so that they learn what they get attention from, and it's not that negative reinforcement. And then we move to timeout once we teach them. I think sometimes, and that's one of the big pieces of sensitive disciplining is making sure that we're teaching children behaviors that we want to see more of, because sometimes as parents, we expect kids to know what we don't want from them without teaching them. So sometimes that's just an expectation and we don't really teach it. So we talk about ways to kind of teach that early on so that we don't have to utilize some of that discipline later on. So gaining empathy for their child and what their child might be experiencing, that kind of goes with that. So, especially 3 and under, we're looking at like 1 and 2 year olds really taking that opportunity to teach that, because they experience distress more than behaviors. And so talking to them about how to manage that dysregulation and that distress so that they're not seeking negative attention later on that leads to other behaviors. And so remaining emotionally available for that dysregulation so that we can manage it. It's super hard. And it's especially super hard when you're working on dealing with a flood of emotions, because now you're in recovery. So it can be really difficult, but gaining some empathy for the child. So again, we're shifting more towards understanding that empathy for the child. So building reflective capacity really does look at the cognitive development, and it's linked to that, right? Because we know that, again, co-regulation has to happen before independent regulation occurs. And that builds on attachment and ability to form relationships, which builds on our brain development and leads to cognitive development. And so we know that all of these kind of run hand in hand, right? It's linked to all of those complex relationships and even disappointing relationships, right? So learning how to handle that when you have somebody that's there for you consistently and can help you regulate some of that dysregulation, even when you have some of those disappointing relationships, then you know how to kind of manage that throughout. And so that reflective capacity really opens parents up for that so that they know how to be available, so they can step back a little bit, allow a disappointment to happen, and then come back in and remain still emotionally available. That can be hard. So building a reflective capacity also includes re-experiencing emotions. So this can be really difficult and trying, especially, like I said, we look at the population we're working with, a lot of trauma and a lot of complex trauma. Those emotions can be very triggering. So sometimes this work can be a very slow and intense process. And so really understanding that as providers too, because trauma runs deep. And so when you're doing some of that work, just understanding that, sometimes these relationships are being kind of put on hold because it's triggering these emotions. And that's what we're really trying to heal. Evaluating different aspects of what is going on within that dyad, where some of these emotions are being kind of evoked or triggered, and then working to heal that. I just like this quote. I like to include quotes every now and then. Practice staying connected to yourself, even while taking care of another. Right. And so I feel like, especially working with pregnant and parenting moms who are, I feel like, especially in recovery, like they feel like they have so much to do and to catch up to, and so little time to do that. And then they experience this shame and guilt that really makes them feel even worse about it. So I really work on self-care and taking care of themselves so that they can be available for their little one, and how important that is. And that it's a slow process and it's not going to come right away, right? So just some techniques on what can build some reflective capacity. We work on serve and return, and what we teach parents is that, your baby puts out, it's like tennis. So your baby hits the tennis ball to you. They're cooing, they're cawing, they're crying, whatever they're doing, right? And you're going to return that emotion. You're going to return a response, and how important that is in a reflective capacity. And if you have a hard time returning, what's going on with you, right? What is about your serving technique here that is going on that you can't hit that ball back? And so it allows us to identify and really reflect on that. But it also, in the same time, is teaching the parent that it's really important for us to respond and return this back, right? And when you play tennis, you have to hit it back and forth, or there's no game going on, right? So we need this game to go on, and we need it to continue. You got to keep that ball in the air. How can we do that? How can we make that happen? And how important it is for attachment. So we talk about that, and that allows us to build that reflective capacity. Reframing, again, having some of those adequate perceptions and making sure that we're reframing when they're not able to have those adequate perceptions, but yet at the same time exploring what's going on that is creating some of these perceptions, right? And how's that reframing helping you, and how's it helping the baby? Because again, we're moving towards building some empathy for that baby. So really looking at how it's helping them as well. Limit setting. So I talk about my chaotic canoe. So like, you want to keep your canoe floating down the river nicely. One side is rigid, one side is chaotic, and we want it kind of in the middle. Limit setting helps limit setting in a way where you're not rigid and things aren't completely chaotic, allows things to stay afloat right in the middle, right? And so we talk about limit setting and how important that is, and how important it is for babies to feel safety, security, predictability, and know what's coming next, right? That helps them build attachment as well. And so that's really important. And so we kind of go over some of those techniques. Of course, social emotional development. We talk about social emotional development, and sometimes, especially preemie babies, can be a little bit delayed with some of this. So we talk about ways to kind of build that up, and how each baby is unique and develops in different ways, and for parents to not get too overwhelmed with some of that. So, when you go to a pediatrician, they tell you every developmental milestone that your baby needs to be at, but we don't always hit on that social emotional piece. So we really try to educate some about that and the child development and how important that is. And I think my I do this often in my pregnant and parenting moms group, but we go over development all the time, and this is something that parents request all the time when we talk about what they want to talk about, what they want to go over, and this is something that they always want to go over and just be reminded of. And I really feel like education is so very important in empowering parents, because I see these moms like take this education and run with it and like really work towards it. And so I think the same way. So maybe because I think similarly, like I need a reason to why something's happening so that I know how to handle it. And I think sometimes we forget to give some of those reasonings, but through some child development, education, social emotional development, and education, we can provide some of that. So I love using this. So T. Barry Brazelton's touch points, I love pulling that in, and I use it with my reflective work. These are the guiding principles. And because I can't remember to use every one of them in every session, what I tend to do is I take one of these. So I have one right above my head here. And then at my desk at work, I have one right above my head too. So I take one of the principles every week, and I kind of interject it in every session, no matter what we're working on. Now, granted, there are some sessions I absolutely can't, but I try to interject one in every session, right? So recognize what you bring to the interaction. And this is as a parent, right? Like what is the parent bringing to the interaction? So many times we have parents that come in that feel like they're failing or they're not doing something right or something's going on with their child. And so we talk about what it is they bring to that interaction, look for opportunities to support mastery, right? Like I talked about that mom that was like pulling down her robe and still bottle feeding with skin to skin. That's mastery, right? Like I want to support that. I want to promote that. And I want to promote what she's doing well. And so really looking for those opportunities. Acknowledge and respect each family's culture, understanding what some of their beliefs are and supporting those beliefs as much as I can and respecting that and finding their culture within that and talking to them about the positive attributes that can bring, right? So using that, use the behavior of the child as your language. So this one is great. This one's kind of easy to use when I have sessions. It says, so what is the child trying to say with this? Especially doing infant mental health, kids 5 and under, if they're having behaviors, it's for a reason. So what is that behavior saying, right? What's going on with them? What do you think they're trying to say? This is also opening up that reflective capacity for them to build empathy. Value disorganization and vulnerability as an opportunity. So I talk about this one all the time because we talk about through each developmental stage, kids will regress and kind of disorganize. So it's not really a regression and parents will be like, oh my gosh, they go back to these behaviors, to these actions, or they're not eating again. And so we talk about how they get a little disorganized, right? And they need to be regulated and they're vulnerable at that time. And you're vulnerable as a parent, right? So this is where that reflective capacity works, because when babies, especially when they regress, right? When babies regress around 6 months and kind of go back to that sleeping piece where they have a little bit of a difficult time sleeping. And then parents are like, oh no, I can't be up all night again. This is regressing. And we're like, let's value this disorganization, right? They're moving forward. They're moving forward in their developmental milestone. And wow, you're vulnerable and they're vulnerable, right? Let's support this. And how can we support this? So we look at this as an opportunity for growth and development. Be willing to discuss matters that go beyond your traditional role. So our traditional role as a provider and parents, right? Part of building a reflective capacity is also making sure that individuals have resources they need. And sometimes I have to spend a session on helping individuals get a specific resource. But the reality is they're not going to be able to reflect and be open for that serve and return if they don't have somewhere to sleep or they don't have food. And so really looking at our roles within that. Focusing on the parent-child relationship. So again, moving from that individual to the dyad. And value passion wherever you find it. So exploring passion and finding out how to support that within parents. Interventions that use specific reflective capacities. So child-parent psychotherapy. So these techniques I use a lot with when we talk about really looking at signals, identifying signals and how to reflect them, opening up how to respond to those signals, right? So we use a lot of CPP with that. Circle of security is a great treatment for, it's a group therapy, and circle of security allows parents to remain emotionally available and responding to their children. So it teaches you a way, and we'll watch a little video, but I'm going to look at my time, but it teaches a way to kind of step back and allow your children to be dysregulated and then step back in and remain emotionally available. Attachment biobehavioral catch-up is about understanding your attachment, how your child's physically responding and then emotionally responding and how to catch up to that, right? So some signs to kind of look for that. And then parent-child interaction therapy, and we do a toddler version that teaches emotional regulation and how to regulate your emotions while teaching them some of those behaviors you want to see. Okay, so here is the video. I don't know if I enabled it, so I hope you can hear it. Here is the video of the circle of security. It talks about the shark music and how you're triggered with your emotions and you respond as a parent. Oh no, it's not going to play it, I don't think. Maybe it's not in there, right?
If you send me the link, Amanda, I can put it in there or at least attach it to the recap too.
Perfect. We'll do that. We'll do that since we're running a little behind. So I'll just explain this a little bit. So this kind of goes over a technique that's used in the circle of security, but we really can think about it in all angles, right? And so the shark music is like, if you think of the shark music, like in Jaws, you think of dun 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 dun, right? It just like, it raises your anxiety. And so what it talks about is like, there's specific things that your children will do that kind of trigger that shark music, like dun 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 dun, and then you start to gain some of these emotions, whether it's fear, anger, like sadness, or just the stimulation, right? And you respond that way, and then it creates this kind of interaction where then they respond that way, and then it's one right after the other. And so it talks about being aware of your own shark music as a parent, so that you're not responding that way and building on this emotion of your child, and that you're able to regulate that emotion instead of just building into it and feeding into it. And I think that that's a hard concept sometimes to identify, but it's a really important piece, and it can help reduce your anxiety as a parent. And especially when you're working with individuals in recovery who are trying to figure out their shark music all over the place. And now they're looking at remaining emotionally available for their children. And at times, and, I think of, I had a parent that one time we were working on her, she would go for visitation. And when she would go for visitation, she was in a public place. So it was really not real personal to begin with. And then she was worried about the placement. So she was always looking over the baby for different bruises. And so the minute that the baby would have any distress, her shark music would play, right? And then she would like take the baby into the bathroom and like look through her body. And so we talked about this, and we talked about controlling her own shark music. And then she was able to remain like emotionally available for her child during that session. I mean, it didn't happen just like that. It happened over, by that time she was getting visitation elsewhere, but we worked on it for a long period of time. And that's it. And I'll make sure that I attach that. Let me see if I can move this, Jay, so I can stop sharing.
No problem, Amanda. Thank you very much. Is there any follow-up questions or comments for Amanda?
I'm happy if anybody wants to email me any questions, or if you want any details on anything, or, if you have a case that relates to this and you want to send it in, we can talk about it next time. That's totally fine too.
That sounds good. Everybody will get a copy of the slides, so be sure to look those over. And like Amanda said, submit any questions or cases you might have around those. So we appreciate it, Amanda. We are going to go ahead and transition and do the Zoom poll for topics and speakers for 2023. So it's just one open-ended question. What topics and/or speakers do you want to hear in 2023? All comers. We want all the information. Give it to us. We'll then sift through it and try to make it work and put it together. So I'm going to leave this poll up for a couple of minutes. So it'll seem like it's long, but please take your time and fill it out. We would really appreciate it. We want this to be beneficial for you guys that are participating. So we want you to make sure you're hearing topics you want to hear about and from speakers you want to hear from. So give me a second. I will pull up the poll. And all right. Was everybody able to see that? Seeing a head nods. Okay, good. All right. Please go ahead and input your information. Like I said, we'll give it a couple of minutes. Had a couple people answer. We're going to give it another minute. Please don't be shy. There are no wrong answers. About 30 more seconds. Okay. And pull a C. Let's see. Doc only lets us do so many characters. Other addressing newer substance. Okay. Nope. If you ran out of room, I understand. Zoom only lets us do so many characters. So thank you for that. I appreciate it. We'll make note of that. If there is anything else you think of, put it in the chat while we're still on the session, or email it to us. Like I said, we're going to take the month of January to really put this together, send it out to everybody, start scheduling, the speakers and things like that. So we have a little bit of time. So don't feel like if you didn't give your answers here today, you can't give it to us later. But I really appreciate everybody who participated. Jen, I know you're up for a case. We have about 10 minutes. Do you want to still do that, or did you want to hold it to February? You could lead off the session. It's your call. Oh, you're on mute.
I was gonna say it. We can hold off. It may get more interesting by then.
Okay. That's totally fine. Then this will kind of wrap up the session then. Just to let everybody know, again, we're taking a break in January. We'll start up in February. It's February 13th. Same time, same Zoom link, nothing changes. It'll just be for 2023. And like I said, please let us know if you have any ideas for cases or topics, anything like that. You guys are what are driving the sessions. So just let us know. All right. Really appreciate it. Happy holidays to everybody. Take care, and we'll see you in 2023.
Thanks, everyone.